Okay, so good evening, everyone. We're gonna give a couple of minutes to allow our participant to join us. Thank you. Okay, so for our colleagues who have joined us now, just a couple of minutes and we will start. Okay, great. So Assalamu alaikum, everyone. Good evening, good morning, good afternoon, doctors and colleagues who are virtually connected. We delightfully welcome you all to our second part of our educational series about cancer metabolism. Today we're going to discuss about the role of pentose phosphate pathway in cancer progression and therapy resistance. So during this coming webinar, we're going to share the latest evidence-based practice, and we're going to learn from our professional experts and aspire our daily pharmacy practice. I would like to thank Dr. Usama Tabbara for the availability of this platform to gather us all around the world to discuss updated guidelines and knowledge all over. In the coming 45 minutes, Dr. Sa'a is going to discuss about the role of pentose phosphate pathway in cancer progression and therapy resistance. So with no further delay, allow me to introduce Dr. Sa'a. So Dr. Ahmed Sa'a is a senior research and medical director of the Egyptian Foundation for Research and Community Development. After graduating from the Faculty of Medicine at Alexandria University and finishing a neurosurgery residency for 3 years, Dr. Sa'a traveled to USA and acquired a postgraduate diploma in neurometabolism from Johns Hopkins University, USA, in the pursuit of understanding the underlying metabolism affecting refractory epileptic patients. That is when he understood the powerful impact of a ketogenic diet on cellular energetic, including cancer cell metabolism. He pursued a career as a research fellow in cancer molecular biology and metabolism at Boston College, USA, working in their labs hand in hand with Professor Thomas. They have co-authored multiple scientific papers together. Dr. Sa'a didn't stop there, but wanted to know more about cancer at a submolecular level, and he continued to study and has finished a postgraduate diploma in clinical applied biochemistry from Harvard School of Medicine, USA, a postgraduate diploma in epigenetic and gene expression from Melbourne University, Australia, and finally, a postgraduate diploma of clinical nutrition and metabolism from National Nutritional Institute, Cairo, Egypt. Dr. Sa'a has finished his laser practice license certificate for use of Class 3B and Class 4 laser in photobiomodulation and photodynamic therapy and laser ablation. Now, being the senior research and the medical director of the Egyptian Foundation for Research and Community Development, applying his science in clinical metabolism, cancer metabolism, and clinical applied biochemistry, hoping to develop better outcomes for cancer patients using his methods to optimize conventional therapy provided to cancer patients and improving their outcome and quality of life. So allow me to thank Dr. Saab for joining us today. Doctor, the floor and mic is yours. Thank you.
Thank you very much for this very good introductions. I'm very happy and I'm very glad to be with you for the second session of Cancer Metabolic Series. And I hope we continue to doing a lot of sessions all over this time. Today we will gonna talk about the pentose phosphate pathway and the role of it in cancer metabolism. Allow me to share my screen first. Okay. So, in the last part with the cancer metabolism, the first sessions we gave, we highlighting the importance of the cancer metabolism and how the cancer metabolism is associated with the tumor progressions and should be included in standard of care and therapy. And I'd like to review very quick what we say in the Warburg phenomenon. And we say that Otto Warburg is the first scientist who explaining the cancer metabolism. And he explained that the cancer metabolism is starting by using glucose as a primary source of energy in tumors. And the tumor cell is using this glucose by the different way than the normal cell. Instead of oxidation phosphorylation, they tend to ferment the glucose even in presence of oxygen. And because the fermentation's power giving so much less energy than the oxidative power, so cancer cell is tending to increasing the uptake of glucose more and more. And first, Otto Warburg explaining this as a defect in the cancer mitochondria. Then we highlighted in the first lecture that it's not a defect in the tumor mitochondria, it's some kind of accommodations effect. Tumor cell is accommodating to increasing the glucose utilization and increasing the glucose receptors. One of these benefits of using glucose as a source of energy instead of fermentation power, instead of glucose in oxidation phosphorylation.
Dr. Sa'a?
Yes.
If I may, are you removing your slides? Or
No,
not
I'm
yet?
not moving my slide yet.
Okay. Just
Okay.
so, thank you.
Yeah. So one of the most important phenomena of the cancer to increasing the glucose utilization is increasing the rate of pentose phosphate pathway. So first, what is the glucose step metabolism in the normal cell versus the cancer cell? Okay, so glucose is uptaken through the GLUT receptor or glucose transport receptors. Then it underwent a hexokinase and a hexokinase enzyme to being converted to glucose 6-phosphate and enters the phosphate pentose pathway. The phosphate pentose pathway containing two arms, oxidative arm and non-oxidative arm. In the oxidative arm, we producing NADH and NADPH as a coenzyme that protects the cancer cell from the oxidative damage of the DNA. In the non-oxidative arm of the pentose phosphate pathway, we producing ribulose 5-phosphate as a building block for the DNA. So the main function of the pentose phosphate pathway is the oxidative arm, which is producing the reactive oxygen species scavenger or antioxidant system, NADH and NADPH, and the non-oxidative arm to producing the ribulose 5-phosphate as a building block for the DNA. Also, the glycolysis ending by starting with the pentose phosphate pathway and ending by converting the glucose 6-phosphate into pyruvic acids or the pyruvate. Then the fate of pyruvate, either it's converted to the lactic acid through the lactate dehydrogenase enzyme, like in case of cancer, or it entered the mitochondria as acetyl-CoA, and this is happening in the normal cell, not in the cancer cell. And it ends up by oxidation phosphorylation. So this is a step of carbohydrate metabolism in normal and in cancer cell. In normal cell, some of the glucose going to pentose phosphate pathway, and some of it is converted to pyruvic acid. Then the pyruvic acid going into the mitochondria in the form of acetyl-CoA. In the cancer cell, all of the glucose is directed toward the pentose phosphate pathway to producing lactic acid at the end product from the conversion of the pyruvic acid to lactic acid, which is called Warburg phenomena. And in this pathway, we're producing the pentose phosphate, the pathway end product, which is a net pH and ribulose 5-phosphate. Okay, this is the recap of what we say. There's a step of glucose metabolism in cancer cell, it being directed to the pentose phosphate pathway to producing ribulose 5-phosphate and producing net pH, and it ends up by lactic acid to producing energy and acidification of the tumor media. So,
okay, Dr. Ahmed. Sorry,
yes.
but we are not seeing your slides as moving on. It's just so can you do please enable editing?
So you're not seeing my slide moving right now?
Yeah, no.
Okay, hold on a second. Okay, so now is moving now?
No, did you share your screen? You need to share your screen first. Okay, can we put it in the slideshow mode?
Yeah.
Okay,
so
great.
Now it's working?
Yes.
Okay, good.
Thank you so much.
So I'm so sorry about this.
No, sorry for interrupting.
No, not at all. So the step of the glucose metabolism in cancer, we say that the glucose is converted to glucose 6-phosphate. Then it enters the pentose phosphate pathway, producing pentose, ribulose 5-phosphate as the DNA nucleotide in the product or building block for the RNA and DNA, and at the same time producing net H and net pH. Then it's ended up by pyruvic acid to convert it into lactate, and this is what's happening in the cancer cell. So glucose to be utilized in cancer, it should be passed through the pentose phosphate pathway. It's a branch from the glucose 6-phosphatase. Net pH and ribulose 5-phosphate are the end product of it. And they shunt the carbon back to the glycolytic or glycogenic pathway. Pentose phosphate pathway demonstrated a major regulatory or cellular reduction, oxidations, hemostatic, and biosynthesis. So as we told you, cancer cell, when it's being under a high level of oxidative stress, it relies on the pentose phosphate pathway to producing net H and net pH to get rid of this oxidation. So imagine glucose 6-phosphate is converted into multiple steps, and through this multiple step, this is the non-oxidative phase ending by ribulose 5-phosphate, and the oxidative phase producing net pH plus H or net H plus H, which both of them can provide the electron ions or the hydrogen ions into the reactive oxygen species and buffer the hydroxyl group into waters. So imagine that the patient receiving radiotherapy, and one cause of the radiation damage to the cancer cell is by producing hydroxyl group as oxidative stress. So when the radiation producing high level of hydroxyl group to kill the cancer cell can have the ability to buffer this hydroxyl group and resist the radiotherapy through reactive oxygen species scavenger or NADH and NADPH. Okay, again, remember that one of the most antioxidant system, especially in the red blood cells, is the glucose 6-phosphate dehydrogenase efficacy or the pentose phosphate pathway. And that's why the patient with the glucose 6-phosphate deficiency having a hemolytic anemia, because they have a problem with pentose phosphate pathway, so it's not working well. So there is no NADH and NADPH, or there is no antioxidant in red blood cells. And because red blood cells didn't contain mitochondria, it's only containing cytoplasm, and the all energy obtaining from red blood cells is obtaining through aerobic glycolysis. And that's why pentose phosphate pathway is crucial in providing the NADPH and NADH, or the antioxidant to red blood cells, like the case of the hemolytic anemia in case of fibrosis. So, what's the role of pentose phosphate in cancer metabolism or in normal metabolism? Pentose phosphate pathway increasing the malignant transformation, so increasing the DNA synthesis, as we say, increasing the building block of ribose 5-phosphate, increasing the ATP productions because it's the gate for aerobic glycolysis, which is the energy source of the cancer cell, increasing the lipid synthesis, and also pentose phosphate pathway increasing the tumor invasion by acidification of the media or production of the lactic acid and decreasing the reactive oxygen species level. And this is called tumor invasion. It increases cell proliferation by the same mechanism, and it can cause a therapy resistance by decreasing the reactive oxygen species level, which is the cytotoxic effect of the most chemotherapy and radiotherapy, decreasing the pH, which is decreasing the drug penetration's ability to the cell whenever it's having a high lactic acid or high pH, and it increasing the drug detoxification effect. Also, the pentose phosphate pathway increasing the angiogenesis by phosphorylation of vascular and cellular growth factor receptors and increasing the NO senses. Also, pentose phosphate pathway can protect the cancer cell from the apoptosis by decreasing the reactive oxygen species and increasing the DNA repair. So, long story in short, pentose phosphate pathway is very important to the cancer cell, and it's one mechanism why the cancer cell is tending to increasing the rate of pentose phosphate pathway, because it gives the cancer cell the ability for the malignant transformation, the invasion, the cell proliferation, and therapy resistance. So, in this paper, they're highlighting the relationship between the pentose phosphate pathway and cancer, and as we say, the synthesis of ribonucleotide, synthesis of NADPH and NADH as a scavenger of reactive oxygen species is the main benefit of the pentose phosphate pathway for the cancer cell. The radiotherapy resistant is the most common example for the resistance because of high level of pentose phosphate pathway. So think about this. The radiation or the ionizing radiations having two damaging effects on the DNA. The direct damage of the ionizing radiation into the DNA and the indirect damage. The indirect damage is not the effect of the DNA directly, but it's the effect of the ability of ionizing radiation to ionize the water molecule, the H2H, the H2O, inside OH and O. So by ionizing radiations, water is converted to hydroxide group or oxidative group that oxidize the DNA and cause the damaging effect to the cancer cell. So if the cancer expresses a high level of pentose phosphate pathway, they having the ability to ionizing or to buffering the ionizing molecule or the oxidative molecule, which is hydroxide radical, into waters and causing therapy resistant to the cancer cell. Also, we noted that a lot of chemotherapeutic resistance mechanism is depending on the pentose phosphate pathway. They say that the pentose phosphate pathway is playing a biovital role in maintaining the high cell proliferation rate and representing the advantage for the cancer cell. In particular, the oxidative branch of pentose phosphate pathway play a role in oxidative stress and seem to be involved in cisplatin resistance. And in this paper, they highlighting that the overexpressions of the enzymatic activity of the pentose phosphate pathway can be act as precursors or investigations to predict the cisplatin resistance before applying the treatment itself. So imagine that we having a measurement of the enzyme that involved into the pentose phosphate pathway and give us an impression that the pentose phosphate pathway is highly upregulated. So the patient is most likely will having a resistance for the chemotherapy, and we're starting to downregulate the pentose phosphate pathway before giving chemo or radiotherapy. So in this lecture, I'm trying to highlight the diagnostic and the therapeutic target of the pentose phosphate pathway, how we diagnose or indicate the high level of pentose phosphate pathway in cancer cell, and how we can therapeutic target the pentose phosphate pathway if it's increasing to decrease the level of expression of this enzyme, to decrease the resistance for the chemotherapy and radiotherapy. So in clinical setting, there are two diagnostic lab tests that indicate the phosphatase pathway activity. The first one is the glucose 6-phosphate dehydrogenase activity, and this activity can be measured quantitative or qualitative in the liquid biopsy, or even in the macrophage of the circulations. TKTL1, which is a transcytolase like 1 activity, is transcytolase like 1 activity in the main enzymatic process in the non-oxidative arm of the pentose phosphate pathway, and this also can be indicating the tumor resistance or tumor progression through increasing the pentose phosphate pathway. So mainly, these two enzymes can be ordered before giving the chemotherapy and radiotherapy to having an impact or indication of this therapy resistance. In this paper, they're trying to investigating the role of glucose 6-phosphate dehydrogenase and correlation with the tumor immune activity and programmable cell death. And they found that there is a huge role of glucose 6-phosphate dehydrogenase in tumorigenesis and cancer chemoresistance. The normal level of this enzyme is ranging between 5.5 to 12.5 international units. It's never being above the normal range, except in the neonates. But in cancer cell, they found that deficiency of glucose 6-phosphate is starting from 10 to 60% lower than the normal range, and over 10.9 is considering high activity. So if you perform this test, the glucose 6-phosphate dehydrogenase activity, and you find it above 10.9, this is most probably a high level of pentose phosphate pathway in the cancer. All these cancer cells expressing a very high level of the glucose 6-phosphate dehydrogenase and having an effect on the tumor propagation itself. So there is a strong relationship between the glucose 6-phosphate dehydrogenase and the tumor cell resistant to the cancer, to the chemotherapy or immunotherapy. The transcytolase like 1 activity, it's specific and regulated in different human cancer cells. Its overexpression predict the poor patient survival, increasing the TKTL1 expression, giving an effect on the activation of the phosphate pentose pathway, leading to enhanced cancer cell growth and survival. There is a multiple study and research and even clinical trials performed as a transcytolase like 1 activity test since 2012, the years they discovered this novel blood test. And they found that this test is very specific to the cancer cell, and it can indicate the early progressions or the reoccurrence of the cancer cells more specifically than the PET scan itself. So this is a diagnostic tools we have in the market, the transcytolase like 1 activity and the glucose 6-phosphate phosphate dehydrogenase. So the therapeutic target, how we block the metabolic pathway of the pentose phosphate pathway if we have a marker of elevation of this pathway. First, we can interfere with the substrate itself. The substrate of the pentose phosphate pathway is the glucose. So any way of interfering with the glucose can decrease the activity of the pentose phosphate pathway. Or we can interfere with the rate-limiting enzyme, hexokinase, glucose 6-phosphate, or transketolase activity. Any of these enzymes is rate-limiting enzyme, and once you interfere with one of them, you stop the PPP activity. So the first therapeutic strategy is decreasing the substrate, which is the glucose. We can use a competitive inhibitor on the GLUT receptors, like 2-deoxyglucose. It's an isomer of glucose, having a high ability and high affinity for the GLUT receptors more than the glucose itself. And that's why they found a very good therapeutic effect of the 2-deoxyglucose in the form of decreasing the energy production inside the cancer cell and interfering with the PPP. But unfortunately, it is still in the preclinical trial because of the high toxicity to the normal tissue. So there is no specificity, there is lack of specificity. So it's attack both the normal cell and the cancer cell. And as we say, that the red blood cell is exclusively dependent on glucose or pentose phosphate pathway and the antioxidant capacity. So the most common side effect of the 2-deoxyglucose is the hemolytic anemia, and that's why it's still under investigation in preclinical trial. And they try to modify this drug and load this drug over nanocarriers that can protect the normal cell and deliver all the cargo inside the cancer cell, but it's still under trial. So the competitive inhibitors is not on the table right now. The second thing we can decreasing the glucose substrate and decreasing the PPP is by using the nutritional ketosis or glucose starvations. So fasting mimic conditions like ketogenic diet. Both of them is selective glucose starvation on cancer cell while providing the ketone energy for the normal tissue. So this have a specificity to the cancer cell, which is the ketogenic diets, and the nutritional ketosis having a very specific target to the cancer cell while sparing the normal cell away from the damaging effect because it's providing the ketone as an alternative source of energy. So since 2009, we're trying to amplify the effect of the nutritional ketosis in the form of the fasting and fasting mimicking diet and low carbohydrate ketogenic diet and the adjuvant cancer therapy. And they concluding that the ketogenic diet enhances the oxidative stress response in the tumor cell. Why? Because the low carbohydrate in the diet reducing the ability of the tumor to sensitize the net pH via the pentose phosphate pathway. And one of the side effects of the ketogenic diet is the hemolytic anemia because of the glucose 6-phosphate dehydrogenase activity or deficiency. So in the patient with the glucose 6-phosphate dehydrogenase deficiency, they having the ability or they having the chance of developing a severe side effect in the form of hemolytic anemia because of the effect of pentose phosphate pathway. All of us know that the ketogenic diet is FDA-approved diet used for controlling the drug refractory epilepsy. In this case series or case study performed in Saudi Arabia, they found that one patient experiencing the hemolytic anemia after being on the ketogenic diet because the high oxidation damage in the red blood cells, and when they perform enzymatic assay for this patient, they found that this patient is already suffering from G6PD deficiency. That's why using ketogenic diet can affect this enzyme in cancer cell. So in these papers, they try to figure the enzyme that work in the pentose phosphate pathway or regulate the pentose pathway and expression of this enzyme under the ketogenic diet. So in these papers done in 2014, they concluding that the transketolase like 1 activity, which is the rate limiting enzyme in non-oxidative arm of PPP, is associated with a more active disease and worse prognosis. And they found that the ketogenic diet reducing the level of TKTL1 and increasing the level of TKTL1, predicting the development of end-stage disease. So there is a strong relationship between high level of TKTL1 and the tumor progressions. And they found that when you apply the ketogenic diet to those patients with high TKTL1, their TKTL1 level is dropped. And that's why we're concluding that survivals and tumor response to therapy will be better if you under glucose restriction pentose phosphate pathway regulations. Okay, so the only way we have to interfere with the substrate is to decreasing the glucose in diet. We can't giving competitive inhibitors because it lacks the specificity between the cancer cell and the normal cell. What about the interfering with the rate limiting enzymes? If I have something that making me can tolerate the ketogenic diet, we having another options which decreasing the enzyme instead of decreasing the substrate. As I told you, we're having 2 enzymes that regulate the pentose phosphate pathway or multiple enzymes. 2 of them is the focus of our talk today. The hexokinase, which add a kinetic energy or phosphate group to the glucose and converted the glucose into glucose 6-phosphate, and the glucose 6-phosphate dehydrogenase. So we have multiple supplements that having a potential therapeutic targeting to this specific enzyme. D-mannose is the main sugar found in the avocado, and they found that D-mannose is a potent hexokinase inhibitors. Also, polydietin and D-mannose is another hexose sugars or 6-carbon atom sugars similar to glucose and can be mistaken uptake like a glucose, but it's not glucose. By specific quantity, it can decrease the glucose 6-phosphate dehydrogenase activity. And polydietin is another supplement that is precursors for the resveratrols. And this supplement specifically blocks the glucose 6-phosphate dehydrogenase. So, since they discovered the relationship between the D-mannose and D-hepatomannose, which is both of them are 6-carbon atom sugars, and they started to research this. And in 2018, in Cancer Research UK, they published an article named "A Sugar Supplement Slow the Cancer Growth in Mice." And the meaning in this sugar is a sugar coming from the avocado, the D-hepatomannose. And BBC News, they published that the sugar supplement mannose would help fight the cancers. So, hexokinase is the main enzyme that can be inhibited using the D-hepatomannose, which is the sugars from the avocado, enhance the oncolytic nucleus diversity killing the breast cancers, and they found the anti-proliferative activity of D-mannose against the breast cancer, so the glycolytic inhibitions. But before we move into another supplement, take care that they found that D-mannose is effective in decreasing the hexokinase, but unfortunately, it having a very poor pharmacokinetics. So the absorption of this drug is very poor from the GIT, and that's why it needs to be formulated into IV form or a nanoparticle form to increasing the circulating time and the pharmacokinetic properties of this drug. Mannose is another 6 carbons sugars. It's a monosaccharide similar to the glucose. And in these papers, mannose as sweet option in treatment of the cancer and inflammation, they concluding that the mannose found to be efficiently suppression the tumor by suppressing the glycolysis and enhance the chemotherapeutic agent through decreasing the PPP phosphate. Another papers in 2018, they found that the mannose impaired the tumor growth and enhance the chemotherapeutic agents in mouse. As you see in these pictures, the above pictures is before giving the mannose. The blue pictures is supplementation with the mannose. This is a PET scan of the tumor, as we say here. This is a PET scan of the tumor recovery after only giving mannose or giving mannose with chemotherapy. So, look at this. This is a tumor volume with and without mannose. And if you can see, there's a great difference between using mannose here and without using mannose. Also, these trials conducting the mannose alone, the doxorubicin alone, and doxorubicin plus mannose. And they found that combination of doxorubicin and the chemotherapeutic agent and the mannose is having the most tumor survivals and the decreasing size effect and the highest level of tumorigenicity. Unfortunately, we have in our body an enzyme called phosphomannose isomerase. Phosphomannose isomerase can convert the mannose 6-phosphate into fructose 6-phosphate and then into glucose 6-phosphate to be using in the pentose phosphate pathway. And this is different in normal peoples. Not all the people having BMI or phosphomannose isomerase activity, but some of them having the phosphomannose isomerase activity. And they found that some of the tumor developing the phosphomannose isomerase activity that can convert the mannose 6-phosphate into glucose 6-phosphate and being used as a source of energy and substrate for the pentose phosphate pathway. So instead of inhibiting the BBB, it's stimulating the BBB. But fortunately, and for our good luck, the effect of the body or the capacity of the body to producing the phosphomannose isomerase is limited. So if the activity of the phosphomannose isomerase is higher than the amount of mannose in the diet, it increases the glycolysis and it can increase the tumor volume. However, if the D-mannose is with very high dose, exceeding the capacity of phosphomannose isomerase activity, if it's present, so it leading to starvation because of the glycolysis inhibition and decreasing or blocking of PPP. So, because of this, we need to be very careful when we're using the mannose as a supplement in cancer cell. We need to give it with a very high dose instead of low dose. And this high dose is up to 3 grams per day in the clinical trial. But again, the mannose is having a poor pharmacokinetics, and that's why we're needing to encapsulate the D-mannose inside liposomal nanoparticles to increasing the pharmacokinetic of this drug and increasing the circulation time of this supplement. In these papers, they specifically targeting the mannose and phosphomannose isomerase regulation energy, and they concluding that mannose load, which increasing the high level of the mannose, exceeding the processing capacity of the phosphomannose isomerase, inhibits the leukemic cell proliferation and decreasing the energetic metabolism. In the tumor-bearing mice, they giving a normal diet with the chemotherapy and the mannose diet with or without the chemotherapeutic agent. And they found that mannose diet alone, okay, having a good effect on the tumor volumes, or Pentose diet with the chemotherapeutic agent having the most favorable response. Also, and mannose is a monosaccharide that's similar to glucose and uptaken by the same receptors, so we can tag the chemotherapeutic agent with a D-mannose as a tagging molecule to target specific target a tumor cell. And once it's been targeted and being absorbed through the GLUT receptors, we're having a dual effect. The effect of the cargo, which is a chemotherapeutic agent, and the effect of the D-mannose on the glycolytic inhibition or PPP blockage effect. That's why there is a huge pharmacological industry right now trying to use a combination of nanoparticles with the methotrexate and mannose nanoparticles. So in this, the mannose is linked to the methotrexate in the nanoparticles form, or even through adding the D-mannose to the photosensitizers like methylene blue or chlorophyllin to increasing the damaging effect of photodynamic therapy and thermodynamic therapy. So there is a multiple use. This use is using the D-mannose tagging the nanoparticle in chemotherapy methotrexate, this conjugating the D-mannose with the alpha-lipulinic acid in the photodynamic therapy and immunotherapy, and even accelerating the wound healing. So there is a multiple use of D-mannose to target the cancer cell or the inflammatory cell. So there is a huge effect of the therapeutic targets of the D-mannose. And by this, we finish the first two supplements, which is the D-hepatomannulose, again, which inhibits the hexokinase coming from the avocado sugars, and the D-mannose, one of the two supplements that block the glucose 6-phosphate dehydrogenase. And we show the evidence of the D-mannose efficacy in the cancer cell. Now, we will discuss another supplement, which is called bulidatin. Bulidatin is extracted from Plugium caspitium extract, and this plant is a Chinese plant using as a source of resveratrols. All of us is knowing the resveratrols, but the precursor of the resveratrol is the bulidatin. The bulidatin or the bulidatin is a potent inhibitor of glucose 6-phosphate dehydrogenase enzyme, and they found that it suppresses the malignant proliferation in both vivo and vitro studies. The glucose 6-phosphate dehydrogenase enzymatic assay, as we say here, it's indicating the redox balance inside the cancer cell. So whenever you're having a high glucose 6-phosphate dehydrogenase activity, you're having a high redox balance to the cancer cell, and you need to suppress this balance. And you need to increasing the endoplasmic reticulum stress and the net H or the oxidation reduction ratio to overcome the reactive oxygen species scavenger resistant molecules. Bulidatin, unfortunately, it's unlike the resveratrol. Resveratrol having a good pharmacokinetic effect. However, the bulidatin is cannot penetrate the cell membrane passively. It needing energy or active mechanism using a glucose carriers or a mannose carriers as monosaccharides. So we start to investigate the effect of novel preparation of nanoliposomal form of the bulidatin to be passively delivered to the cancer cell and to enhance the pharmacokinetic effect of this drug. And we found a great difference between the free bulidatin and the bulidatin linked to liposomal nanoparticles in the form of tumor progressions. So imagine if we conjugate nanoparticles of bulidatin and conjugate it with a D-mannose, so you will have a post-target effect and both therapeutic effect, dual therapeutic effect in the cancer cell. In summary, pentose phosphate pathway, as we say, is a very crucial for malignancy. It provides a redox balance by producing a NADH as a reactive oxygen species scavenger. It produces the ribulose 5-phosphate from the non-oxidative arm as a nucleotide base for both DNA and RNA cells. Pentose phosphate pathway help in cancer proliferations with a different mechanism while resist chemo, radio, and oxidative therapy or any therapy that increasing the oxidative stress inside the cancer cell. And we now know that restricted glucose in diet help in controlling the substrate, but is not sufficiently as anti-cancers. So we're using a dimanose in a big dose or mannose or bulidatin in liposomal form, having a great anti-cancers and chemo sensitivity agents. Thank you.
Thank you so much, Dr. Sa'a, for your comprehensive presentation. Actually, we have one question from our participant, from Dr. Abdel Khaliq. He's asking, is there a link between PPP and lipid droplet formulation in cancer cells?
Yes. Actually, a part of the pentose phosphate pathway is producing both substrate and substrate for another metabolic pathway. So the main metabolic pathway of producing lipid inside the cancer cell is a melavonate pathway. Melavonate pathway is dependent on the NADH and NADPH as a coenzyme. And that's why there is a huge link between the upregulation of pentose phosphate pathway and the synthesis of the lipid molecule inside the cancer cell. And that's why the drug that would initiate a therapeutic target to block the PPP is actually lipid-lowering drugs and being investigated as the cholesterol-lowering drugs because of this.
Okay, great. Thank you so much, Doctor. Now for our participant, we have a set of pool questions. We're gonna give you 2 minutes, 1 to 2 minutes to choose the best answer. It's a single answer. And then we're gonna share the results with Dr. Sa'a for discussion. So I'm gonna read the questions so fast. Question number 1, the pentose phosphate pathway PPE produces a NADPH, RSP, and all of the above. How can the metabolic pathway of PPE be blocked, decrease the substrate, interfere with the rate limiting enzyme, all of the above? Ketogenic diet, increase, decrease, maintain glucose level. D-manophytolase inhibits glycolysis pathway by inhibiting, activating, or both. So we're gonna give you 20 more seconds and we're gonna stop the poll. Okay, so Dr. Sa'a, for the first question, we have 67% of our participants voted for all of the above.
Yes, as we say that the pentose phosphate pathway having 2 arms, the oxidative arm that producing the NADPH and the non-oxidative one which is producing the ribulose 5-phosphate. So the answer of the question is all of the above, both of them. Okay,
great. Question number 2 is, how can the metabolic pathway of PPE be blocked? We had 50% of our attendees voted for all of the above, which is decrease the substrate and interfere with the rate limiting enzymes.
And this is the correct answers because, as we say, any metabolic pathway need to be blocked. We can interfere with the substrate or interfering with the enzyme working on this substrate.
Okay, excellent. So the third question is ketogenic diet. We had 83% voted for decrease glucose level?
Yes, ketogenic diet is one of the fasting mimicking diet that limit the carbohydrate inside the diet, and that's why it decreasing the glucose level in both intracellular or extracellular circulations.
Okay. And the last question, we have 83% voted for inhibiting hexokinase in cancer cells.
Yes, the hexokinase is the rate-limiting enzyme of the pentose phosphate pathway, and this is the main action of the hepatomannulose to decrease or inhibit this enzyme.
Excellent. So our attendees were fully focused during the session.
Yeah.
Great. Doctor, I have a last question prior to ending our session, if I may. You mentioned about the cisplatin resistance in your presentation. So does in Egypt or your cancer research foundation, do you test for these enzymes prior to the patient initiation on cisplatin?
Yes, actually, we start a cross-section study on the resistant patient on the chemotherapy or radiotherapy in 2016, and we found that 83% of the resistant patient for the chemotherapeutic or the radiotherapeutic agent as a different modality, having a high level of either glucose 6-phosphate or TKTL1 or both of them. So since then, we starting to investigate the pulse enzyme and order these investigations before applying the standard of care, any kind of chemotherapy or radiotherapy. And if we found a marker of elevation of this enzyme, we recommend to postpone the chemotherapeutic agent for a few days to perform a quick depletion of the glucose inside the diet, or even giving multiple supplements and retest this enzyme again. And the result is quite joyful when we use metabolism to control the standard of care.
Okay, great. Is this actually a regular practice that is usually done?
No, it's
is
not,
it mentioned in the
unfortunately,
guidelines?
not yet. No,
okay.
Not yet. It's having a high evidence till now, but it's not being till now under the list of the standard of care or the guidelines. But there is a very growing research evidence that support the importance of interfere with glucose metabolism of the pentose pathway before giving the chemotherapeutic or the radiotherapeutic agents. Some country giving the hyperbaric oxygen therapy during the radiotherapy to increasing the oxidative stress and replenish the net pH coming from the phosphate pathway, which acting by the same mechanism which interfere with the hypoxic nature of the phosphate pathway.
Okay, great. Thank you so much, Doctor. Thank you.
You're welcome.
I don't see any other questions. We have our attendees. They are thanking you for this excellent and comprehensive presentation. So
no, thank you for all of you. I know that the biochemistry is very sophisticated, and I'm very happy that you focused till now.
Yeah, you made it simple, actually.
I hope so.
Thank you so much.
You.
So by that, we conclude our session for tonight. Thank you for joining us, dear colleagues. I want to thank Dr. Sa'a and Dr. Qabbani for enrolling with us in a second section from our e-learning IVPN sessions. And of course, we're gonna have part 3, right, Doctor?
Yeah, I hope so.
We hope so, yeah, soon. So stay tuned, dear friends. I want to thank you again for attending. Please note that we will be sharing a certificate of attendance 3 to 4 weeks from the date of the session. Please feel if you have any questions that you didn't submit, you can share it via email, and we can share it with Dr. Sa'a for any feedback. Thank you so much. Thank you for trusting IVPN, and have a nice evening, everyone. Thank you, Dr. Ahmad,
you.
for having you with us today. Thank you so much.
Thank you very much. It's been an honor.
Thank you. It's an
Bye-bye.
honor. Thank you, Doctor.
Thank you. Bye-bye.
Bye-bye.